I'd like to welcome here on stage who will be chairing the session. First of all, Winkler from University of Stanford. Welcome on stage.
Okay.
And Amine Benyamina, Professor of Psychiatry and Addictology at Brousse University Hospital. Amine, whenever you want, the floor is yours.
Are you first?
Yes.
Me first? You first?
Do you need the clicker?
No, just to present Aaron.
Okay.
Thank you very much.
Thank you.
I'm going to speak in French, Aaron.
Oh, okay.
Merci beaucoup, merci beaucoup. Amine Benyamina, Université Paris-Saclay.
Ah, d'accord.
Thank you very much. Merci beaucoup, merci à l'événement WeMind et merci spécialement au groupe Clarion de nous avoir invités pour parler d'un sujet extrêmement important, extrêmement utile et d'un intérêt clinique évident qu'est le TDAH. Alors j'ai le plaisir évidemment de présenter un auteur et puis un chercheur de premier ordre. C'est le docteur et professeur Aaron Winkler que j'ai connu ce matin. Je l'ai poussé, il est allé aux urgences. J'ai voulu lui prendre la place, mais il a résisté. Et non, on a le plaisir de l'avoir avec nous. Il vient d'une école évidemment de prestige, Palo Alto, et université de prestige aussi. Merci Aaron de venir évidemment présenter ton savoir avec nous. Je propose que la grande majorité de la prise de parole, ça ne sera pas moi, évidemment, parce que je risque de le faire pour dire tout et n'importe quoi, mais qu'on essaie de challenger Aaron avec vous. On est parti sur le principe qu'après sa présentation, qu'il y ait un échange avec la salle, c'est un peu le désir d'Aaron et un peu le mien, et c'est la meilleure façon probablement d'avancer sur un sujet de manière pragmatique et pratique. C'est ce qui est attendu a priori pour cette session. Si tu es d'accord, moi je le suis aussi, je te donne la parole Aaron.
Thank you. Okay. Let's see. All right. There it is. Look at that. So, I'm not at Stanford anymore. I'm not a professor. I was, but I left to be able to do more of this work and left the clinic that I started in the hands of a very capable colleague who I trained. So I built a clinic at Stanford to work with adults with ADHD. It is a very difficult thing to do in an academic setting, and we were able to achieve it. My clinic was the 4th attempt by Stanford in 10 years. The others had all folded within a year or two. The administrative difficulties of ADHD are very high. Patients come in late. They throw your entire day off because they're 15 minutes late for their appointments. They don't fill out their paperwork in advance, these kinds of things. The medicine is a controlled substance that then requires multiple hoops to jump through. And in the US, you have to get a new prescription sometimes every month. If the insurance will pay for it, you can do it every 3 months. But for a lot of people, it's every month. And so that requires a lot of additional administrative work on the part of the clinicians. And so things fall apart, and clinics don't survive in academic settings. When I told the people who, my colleagues, sort of further on in the field that I was, coming on to Stanford, and I was so excited, they said, "Good job!" But they knew how difficult it was. But we did it. We achieved it, and it is still standing, and it still functions. And we had to do some specific things to solve some of the problems, and we'll talk some about that here. So I'm just in private practice. And though I did get compensated for coming to speak here today, I was not told what to say, and there was no editorial right. So I have no other, I'm not speaking on behalf of anybody. I do like to put up the names of the clinicians to whom I am indebted. A lot of what I built was only possible because of people who taught me. David Goodman is in Baltimore. He figured out over 30 years how to work with adults with ADHD all on his own. What I do now is an adaptation, and I think much expanded from what I learned from him, but I never would have been able to do what I do without him. Julie and Amy supported me at Stanford, and John and Ben introduced me to ISTDP, intensive short-term dynamic psychotherapy, which is a huge part of how I'm able to do what I do. When I was initially asked to come and talk, the idea was to do sort of a debate. Is ADHD overdiagnosed or underdiagnosed? And they asked me, which side would you pick? And I said, it's both. Right? There is no, I can't pick either side of that because both are true. There is not a single ADHD symptom that isn't normal in the whole population, not one. Everybody floats away from conversations that are boring. Everyone will float away from this talk because it will at some point be boring to you, right? I should ask, actually, how many people in the audience are clinicians who treat patients? Okay, and how many people actually work with people who have ADHD in clinic? And how many people are on the business side or on the operations side working at healthcare facilities? Okay, so mostly clinicians, it looks like. Okay, and also a fair number who do something else. So every ADHD symptom happens in all people. So it's overdiagnosed because somebody can come in and say, I'm having trouble focusing, and really what's going on is they're getting bad sleep, right? But also, and this was mentioned in a talk earlier, anosognosia, there's such poor recall that it's also underdiagnosed. So lots of people who don't have it are diagnosed with it, and lots of people who do have it are missed. So what is it, this thing, this ADHD thing? What is this? I think from a business standpoint, it's an opportunity, right? In the US, there was a study in 2018, $14 billion were spent on direct healthcare costs for ADHD. And then if you included car accidents and drug addiction and all the other things that are consequences of ADHD, it was $103 billion. That was just the US, right? So extrapolate that to the world. There's a lot of money to be made in treating ADHD, but what it really is an opportunity to help. There are so many people actively looking for help, and there's so few resources. Anyone who knows someone who has ADHD, or if you yourself have, like most people who have tried adults who didn't get diagnosed as children, they go looking and looking and looking, and you can find these online places that will do it cheaply, but not very well. And if you actually want help, it's actually very difficult. You can help people understand what it is that they're struggling with, which is more complicated than they realize and goes deeper than they realize. But the treatment is staggeringly effective. It's one of the best, one of the most effective treatments in the whole Western pharmacopoeia, equivalent with blood pressure medicines, right? Like it just works. And when you treat, people become better people. A lot of my patients, the thing that's most incredible is watching them become better parents to young children, to very young children, but also if their child has ADHD, then they learn what that means and what treatment looks like and what you're actually looking for, which is very different than what you expect. There are a lot of hard truths if you have ADHD. There's a lot of difficulty and things that you wish weren't true but are, places where it really is up to you to make change. But the possibility to live a full life is beyond what people expect. This is pretty dramatic, right? So let's make it real. This is a real patient, and this is not unusual. This is Are the translators reading it? Do you need me to read it so the translators will Should I read it so that the translators will translate? Yes? Okay. Everything is quiet. My heart doesn't beat as fast. I can feel things. When I touch things, I can really feel them. I don't know how to say it. I feel more autonomy. I was able to make my bed and I didn't have to fight myself to do it. This is a Stanford student. Very effective person. Didn't know how to feel things. I've been trying to meditate for years because they said it's helpful for ADHD. I would try, but I couldn't do a body scan for more than 5 minutes. Now I can do it for 20 minutes. When I was a kid, they put me in a class to learn how to ride a bicycle, and eventually I gave up because my balance was so bad. Then I came to Stanford, and you kind of have to ride a bike to get around campus. So my friends would help me and push me, but I would still fall all the time. On the medicine, I'm not riding without hands while eating food or anything, like some people can, but I can turn right and left without losing my balance or getting dizzy. Oh, and I can watch a 20-minute video for class before I could only watch for 5 or 10 minutes. There's something I want to point out here. Almost everyone who comes for help with ADHD thinks it's work, right? Sometimes it's their child just got diagnosed and they had some identification during the diagnostic process, but usually it's work. I'm struggling at work, I'm struggling in school. How much of this is about work, right? If you can help someone really understand how deep it goes and what they're really struggling with, then when you treat, work is an afterthought. It gets better, but it gets incredibly better, but it's so secondary to the deeper things. So if this is possible, why isn't somebody already doing it, right? I mean, we have a stimulant medicine, right? Here we are, moving forward, the Industrial Revolution, right? We all need stimulants, right? Caffeine, nicotine, right? These are the things that are driving humans who no longer live outside very much like we used to. So how come somebody's not doing this? Well, turns out they do. And it goes bad. Telehealth company Cerebral agrees to pay $3.6 million in connection with business practices that encourage the unauthorized distribution of controlled substances. This was a company in the US that realized you could diagnose someone with ADHD and they would have to come back every month. You diagnose them with depression, they'll come back once every 3 months, maybe once a year, but ADHD, you get them every month. And so from the top down of the company, they were pushing the clinicians at the bottom to diagnose everyone with ADHD. This is another company that did the same thing. That CEO got arrested. This company is called Done. Digital health company, co-founder, CEO, and clinical president convicted in a $100 million Adderall distribution and healthcare fraud scheme. Same thing, they were sort of pushing their clinicians to diagnose people. So there is a huge business opportunity here, but if you approach it as a business opportunity, it goes very, very sideways, very quickly. You have to approach it from the interaction of the doctor and the patient. Okay, so the interaction of the doctor and the patient, which is terrible. Well, I guess I have to read it all out loud. Increased administrative burden prior to treatment, comorbidities, poor insight, unreliable self-report, unreliable collateral, it's a controlled substance medication, there's a medication shortage, incomplete understanding of the syndrome, stopping medication after use for a few months despite significant improvement, that's frustratingly common. Inability to predict which patients will destabilize with treatment, that's one of the big things that I was able to solve. Stigma in society, medicine, and in psychiatry. There's a lot of stigma against ADHD. I mean, they just don't show up on time and they ruin your clinic schedule, right? Okay, so if we want to focus on actually providing a service to people, we're going to have to solve a lot of this. But people don't get trained. So ADHD has always been the province of child. Right? You do adult psychiatry residency, and then later you go to child fellowship. And ADHD is something that happens in children, right? So adult psychiatrists don't get trained very much. They don't see very much ADHD. Also, there's not that many ADHD clinics in academic settings. So there aren't that many clinics to rotate through while you're in training, right? I mean, I could ask for a show of hands. How many of the clinicians who just raised their hands before, which was maybe half the crowd, felt like they actually got training in how to manage ADHD adults while they were in training? Not a single hand. Not one. Oh, wait, one, two. Oh, we got two. That's fantastic. It's a small minority, but that's about right. So it's pretty hard to find people who already know how to do this. And if you don't have training, it gets messy because ADHD is never the bottom. It's always superficial to deeper trauma. And you don't know how bad that trauma is at the outset. And if you treat someone with a stimulant, you force them into focus. And if they have a deeper trauma, you're going to worsen their trauma symptoms. And they're going to start having somatic complaints, abdominal complaints, headaches, heart racing, things that could be a stimulant side effect. But when you actually talk to them, it's not every day at 11 a.m. when the medication is strongest. It's 3 times in the last month and only at 8 p.m. and always when they were in a fight with their spouse. And it's more about when their heart starts to race, they feel it more. They're more aware of their body, and that scares them because they have trauma, right? You have to be able to predict these things. Otherwise, you end up on a long road of switching out meds, trying different meds, and it doesn't really end. Systems like to rely on testing. That's a good answer. Let's just solve the whole problem. Let's just have a test that does it. The problem is they don't work. Sounds good in theory, but it doesn't work. ADHD is a human experience. So there's no test where you can click buttons or sort cards, see how fast your reaction time is or how quickly you can write, that's going to really find us an answer to what's it like when you walk into a room with new people and you forget all 4 of the people's names immediately, right? So I spent 10 years trying to figure this out. And I was able to solve all of these. I was able to solve how to separate from comorbidities, how to deal with poor insight and poor self-report, how to help people understand the syndrome so my patients don't stop. The patients who are seen using the process that I built don't stop meds. And we can predict with pretty good accuracy who's going to destabilize and get them therapy before giving meds. And I built a structure so that other people can use it. This is a symptom tracking process that I make available for free. You have to do an orientation and sign something that says, I'm not responsible for your patients. But it's freely available. I'm actually here because I talked about this in Madrid, and a doc who came to that liked it very much and ended up translating it into Spanish and introduced me to it, right? Because it works. It really changes how things go with patients. So, yeah, then I left Stanford so that I could have time, because the administrative burden, I couldn't get help with it. And so I've been talking. In the couple of years, I've been talking and sharing this, and more people are using it around the world, which is pretty great. Yeah. So what is ADHD? Right? Is it the thing that we have crafted since we first started talking about it in the 1940s, which has led to what is now the diagnostic criteria in the DSM, you know, the 18 symptoms, 9 inattentive, 9 hyperactive impulsive, right? Is that what ADHD is? You have 5 of these 9 symptoms, you have ADHD, maybe. Is it this thing that was first talked about in Germany in the 1840s? A kid who just can't sit still, right? I think it goes further back than that. I think it goes as far back as people moving into cities and struggling. I think it goes as far back as people being displaced by wars, and parenting being difficult, and people being raised and struggling. Maybe it's just a brain thing, right? Maybe it's just in your brain, and you have inattentiveness, you have hyperactivity, and you have impulsivity that are just unbalanced, right? We could just look at your brain and it's unbalanced, and you know the networks shift inappropriately like that, maybe, and it seems accurate, but I've worked with the scientists who do this stuff and asked them about the math that actually gets us from what we're reading from an fMRI to how we build these pictures. And they will freely admit that we really don't know. There's so many layers of mathematical abstraction that we don't really even know what we're measuring. I think ADHD is an evolutionarily conserved yet unstable adaptation to life and civilization. I think it's a biopsychosocial attachment disorder where something happens when you're 4 over a prolonged period of time that makes it so it's not safe to be aware of what's happening inside of you and outside of you, and you use your imagination to escape from it, right? But then you discover that you're not paying attention, and that's a problem. You don't really know how to deal with that because you're a small child. And maybe you discover that if I just, I'm a wolf, I'm a bear, like if I just go on a hunt, like I'm focused, and you start to learning how to generate intensity, and that becomes hyperactivity. I think it's survived as an adaptation. We have many adaptations that don't survive. I think it's survived because in times of crisis, people with ADHD do incredibly well. Someone with ADHD who moves to a new country when they're 24 may do incredibly well because they can tolerate very high levels of stimulation and feel comfortable, right? Where people with ADHD struggle is when it's quiet, is when it's times of peace, when everything's just moving along stably, quietly, everybody just shows up on time, the trains are working. That's where people with ADHD struggle. There isn't enough stimulation. It has a predictable natural course, which is bad. The life expectancy is 10 years less. You're a quarter as likely to graduate college if you have symptoms that persist beyond childhood. You're 7 times as likely to be on welfare. Lots of prison, lots of car accidents, lots of substance use, right? It's profoundly treatable. You need medicine and you need therapy, right? The medicine gives the stimulation that someone needs and is generating with these disruptive behaviors. You give them the medicine and their brain can calm down. It's like, oh, okay, there's enough stimulation here. Okay. But that doesn't unravel the human experience of the 4-year-old that had developed this behavioral pattern, right? It doesn't fix that. And to fix that, you need real therapy. So how do you do it, right? So how do you actually put this in practice? Well, you can't approach it as a business. We've seen that. That's not going to go well. The first thing is you need clinicians who are willing to deal with it, right? You need clinicians who are willing to see a fair amount of it and start to understand the gestalt of it. You have to train them. You have to train them to understand what they're looking for, right? And specifically. So to ask the right questions. So when you're diagnosing someone with ADHD, you need to know, did it start in childhood? And what are the current difficulties, right? But remember, they can't tell you a lot of times because they have poor memory. They'll over-report things that aren't a problem, and they'll under-report things that are a problem. The way I have come, nice.
Adhd.
Nice. That was great. It was well timed too. Like right in a gap. That was great. Well done. There, yeah. Strong teamwork. You can ask people about things from childhood. Did you get moved to the front of the class? Did you, were you disciplined by teachers? That kind of thing. But what if they were inattentive? What if they were a girl who had perfectionism and she kept herself sitting still in her chair even though her mind was racing, right? And so nobody ever noticed. I have discovered what you can do is you can ask questions that somebody without ADHD won't understand, that get at the adaptations of a life lived with executive dysfunction, right? One of my favorites is how many water bottles, right? Or how many chapsticks, or right, something like that. And somebody without ADHD will say, how many water bottles what? Which is very reasonable. And somebody with ADHD will laugh. They will just laugh because they immediately understand the question is, how many water bottles have I lost? And they know that the answer is thousands, and trying to enumerate it is preposterous. And they don't even think about any of that. You just say, how many water bottles? And they just immediately, right? People who have a sixth sense for whether something is lost or just misplaced. Do I need to replace the credit card? Or will it just show up in a month or two in the towels from the beach? Like, why is it in the towels? I don't know, but somewhere it'll show up, right? Versus just kind of knowing that it's gone and they need to replace it. These are the things that develop over a lifetime lived with executive dysfunction. You can ask questions like this and really get a sense for whether somebody has been struggling with this chronically in many spaces since childhood, even without having concrete data points, although sometimes you can get those too. And then to figure out their current symptom dysfunction, that's what I use the symptom tracking for. And I'll show you an example. You have to be thorough, which in this case means dynamics. So I use the tools of intensive short-term dynamic psychotherapy to, in the intake appointment, offer to bring someone into presence. Someone will say, I struggle with completing tasks. I'll say, is there a specific example? And they'll say, every time I try to write an email. Well, was there a specific example? Every time I try to write an email, and they start to get frustrated, right? Try to get them to actually say, yesterday at 3 p.m. when I was writing this specific email to my boss. They will struggle so hard to bring that up. There's something about the specificity that's really difficult. If when you do that, someone can, in their frustration, realize they came here to get assessed. This is what they want. Specificity will help get the answer to their question, do I have ADHD? And they will push through the frustration. That's someone who's going to do really well on medication, because they can tolerate presence and specificity. A significant percentage of people will freeze, and some people will fully split and project, right? Those people need trauma therapy first. If you give those people a stimulant, those are the people who are going to come back with somatic complaints. They're going to come back with all kinds of difficulties, right? But if they just have about 2 months of trauma therapy, I don't know why it's that long, but that's about how long it is. And they've got some language around grounding. They have someone they can go to when they're struggling with this stuff. Then they start a medication and it works really, really well. That's incredibly important from a systems perspective, to avoid the many, many difficult patients that don't have to be difficult if you just clarify, can they tolerate presence? The last thing is you have to be ruthless. You must be. You have to flatly refuse to ever give a new prescription if it's lost or stolen. I don't care if it was lost. I told you not to put it in a medicine cabinet that was shared. I told you that, right? If it's lost or stolen, you don't get a new one until the next one's due, not ever, right? If you don't do your symptom tracking, we don't move forward. If you didn't complete your intake paperwork, sometimes, the first box will be empty, but all the rest of it's filled out really well. Well, that's ADHD. They just didn't look at the beginning of the form. But sometimes the whole thing is sort of not really filled out because they, maybe their spouse wants them to come and they don't really want to do, right? If they don't really want this, the treatment is going to dramatically change their lives. And even if it's for the better, change is hard. And if they're not ready for that, they're going to get mad at you, right? As they should. You sort of have to, right? You have to be ruthless. You have to be willing to say no. And for a clinician to be willing to say no, it comes back to the system side of things. You need institutional support because you're going to need time to make a diagnosis. You can't do it in 50 minutes and start meds. You have to have at least a second appointment to do the symptom tracking process, get to the diagnosis and then do symptom tracking, not start meds till the second appointment, at least. You have to have a system that isn't going to push you to use tools, these testing tools that aren't actually effective. And you have to be able to tolerate patient complaints. People come sometimes wanting a stimulant. And a system has to be willing to tolerate the complaints that come when a clinician looks somebody in the eye and says, no, I'm not going to do that, right? You're asking me to give you fuel for your self-bulldozer, and that's not what I do. I help people become calm so that they can get in touch with who they really are. Some people don't want to hear that. So for things like this to function, for a clinic like this to function, the institution has to tolerate that sometimes people have to say no, and that's part of the controlled substance situation. So I thought it was important to give you an example of the symptom tracking, of what it actually looks like before we finish. Because it's a pretty important part of the process, this thing where people come in for the first appointment we get to the diagnosis of ADHD, and then I assign them the symptom tracking, which is the CAST ADHD thing I showed earlier that other clinicians can use. And then they go off for 10 days and they track their symptoms. And this is what it looks like. Zoned out during dance workshop when it wasn't my group. Probably like 8 to 10 threads of thoughts. On bike, home from dance plus shower plus laundry. Forgot if I did my entire after shower routine. I did. Open cabinet, forgot what I was reaching for, ×2. Started thinking about other project while I was doing first one, ×2. Got sidetracked on project, ×11. Ran into backpack, didn't see it on the ground. Had to reread ×3 paragraphs during research for mock grant proposal. Distracted by table. That's one of my favorites. Dance workshop, that's not a symptom, that's just a noun. Didn't do laundry until completely out of underwear. Forgot to pee ×3. This is the thing, how deep ADHD goes. It goes to a lack of awareness of one's basic biological cues, because you can generate intensity, it's kind of a hyperactivity, by just avoiding your basic needs. Don't sleep when you're tired, don't eat when you're hungry, don't go to the bathroom when you need to, right? Most people with ADHD do a few of these, right? Because if you just sit and hold it, it generates some intensity. And then 2 hours later, you have to go to the meeting and you're racing out. Oh, you really have to use the bathroom now, so you're quick running to do it. And then you didn't put that, and then you're late to the meeting, right? Nonstop fidgeting when not typing for project. Dance freestyling. Kept forgetting to pee. Wow, I did not realize this was a thing until now. Feeling very good after dance workshop and freestyling. Dance community very supportive, so they were hyping me up a lot. Mine drifted during brunch with friends, didn't engage much. Zoned out, ×3 during dance freestyling session. Zoned out when talking to friends at night, ×3. Switched topics quickly, ×2. Arrived a bit too early for brunch, trying not to be late. 2 important things to say about this. Well, 3, I guess. One is this is an actual patient, and this is not abnormal at all. Like this is what you get. How much of it is about work, right? How much of that is work and how much of it is with their friends? And this is what makes people stop asking the questions of, do I have to take the medicine when I need it? Do I have to take it on weekends? Because once they've done this, they come back and they say, I clearly need, I need this. I can't remember the choreography in my dance workshop, right? The other most important thing about this is that's one day. That's one day, right? She tracked that for 10 days. All of these things happen to everyone. We all float away from things sometimes. We all have to reread the paragraph sometimes. This is completely destructive of regular life. This person can't focus on anything for more than 10 minutes and didn't know it. They would have said, I float away 6 times a day, 8 times a day. They had no idea that they float away 40 or 50 times a day, right? And they would have said it's about work. It also changes when you want to send somebody to their primary care to continue the prescription, because then they can just take their symptom tracking with them in their as part of their package of write-up from you. And the primary care physician will no longer ask, how do you know they have it? Is it real? Do you know for certain that they have it? And again, after they've done the symptom tracking, this is what you get. It was a different patient. What I felt is everything is quiet, like a hot summer day where no one is around. That's the calm I feel. This is what you're going for with a stimulant medication. A stimulant medication should not be, and it helps me do my projects, and I'm more effective at work, and I'm better at my emails. It will be all of those things. But that's not what you're going for. You're going for calm, for their system that is constantly generating intensity to still. The world around me is less stressful. I was at a party the other day. Usually at parties I'm on edge, very tense. I hate it when people touch me. And it was way less stressful. I never thought that was ADHD. I thought that was just me. That's a person who's going to start drinking, right? That's a person who's going to start smoking weed, using marijuana to just deal with the social anxiety and end up with a substance use disorder. The day after the appointment, I was this odd mix of excited and sad, and my friend said maybe I was mourning for the life that I had or could have had. I always thought, how come so many people can do these things and I can't? And that's the stuff that therapy, people need to come to grips with, right? Here's another one, but I won't read it. This is all much more this is all much more effective when people can read the slides. I'm sorry, it's all structured for me to talk while you read the slides. I'm sorry about that. So this is what's possible. And if you specifically structure a clinic where people know how to ask the intake questions, know how to say no, know how to refuse to give medication to someone who can't be trusted with it, or refuse to give medication to someone who won't engage with the treatment, with the diagnostic process. This is readily doable. And I figured I would just put this up here. That's what I got. Happy to answer any questions.
Merci beaucoup. Merci beaucoup, Aaron. Thank you very much, Aaron.
Yeah, thank you.
Ok. Tu nous as montré un peu la manière avec laquelle tu as mis à profit de ta clinique dans ton savoir académique, avec des expériences et des exemples très, très concrets. Puis, à titre personnel, je ne sais pas, la salle va réagir. J'ai beaucoup apprécié ces éléments de biographie et puis cette situation au quotidien que vivent les patients atteints de TDAH. C'est très réel parce que quand on parle de trouble hyperactivité avec déficit de l'attention, parfois, ça ne parle pas beaucoup. Mais par contre, quand on voit dans la vraie vie ce que ça entraîne comme handicap, c'est assez édifiant parce que ce qui est un peu à la mode, j'en parlais tout à l'heure aux journalistes, c'est qu'on a l'impression que, un peu à la manière de dire je suis addict, je suis TDA. Non, TDA, c'est quelque chose qui fait souffrir. C'est pas une qualité, c'est quelque chose qui est pénible au quotidien, qui limite notre capacité à avancer dans la vie sociale, dans la vie professionnelle, en dehors des comorbidités qui sont terribles. Évidemment, les troubles anxieux, les troubles addictifs, les difficultés d'adaptation. Ça, c'est le vrai TDAH, je crois, ce qui justifie évidemment une prise en charge codifiée, qui est le cas maintenant. Je ne sais pas si tu veux réagir à ça avant de parler à la salle.
I agree. I think it's hugely important that both the clinicians and the patients don't understand that that's the burden of symptoms, right? The patients don't realize it and the clinicians don't realize it. And when you try and get people to answer questions for their DSM diagnosis of how often are you struggling with this? How often are you struggling with this? Like, they don't really know. And the clinician also doesn't really know, and we're sort of groping in the dark. And this thing where you have someone actually write it down is very effective. It's very effective for everyone involved. That's what patients want to stay on meds, because this wonderful thing happens where 4 months later people will come back and say, do I really need to be on the medicine now? Right? Are you sure? I think everything's fine. And I will just say, cool, great, and pull up my second clinic note and not even engage with the question. And I will just find, and I'll just start reading their symptom tracking. And I'll read one day, and then I'll say, cool, is that how things were yesterday? And it's like, never mind, because they've just forgotten, but it's all in their own words. So it's their actual life. It's not checked boxes. It's like, this is their real life, and it evokes for them immediately what it was like before they started medication. And that goes away. Yeah. There are microphones if anybody has questions. Feel free to raise your hands. But please, yeah. I'll put my thing back on. Oh, yeah.
Yes.
Hi, good afternoon. Thank you very much for your inspiring talk. I got a very brief and straightforward question, because you mentioned how treatment adherence is something absolutely crucial in terms of preserving the patients in the clinic. Now, what would you say to a patient who comes to you, Doc, I'm absolutely hopeless because my age is 55 and I think there's no longer anything that could work with me? What will be the first straightforward and convincing sentence to tell to this kind of patients?
Well, that's just not true. right? I have many patients. I have 75-year-olds, and that's exactly what they say. They say, you know, is there any point? Is there anything that I, right? The older someone is, the more grief there will be over the time lost, right? When they begin to experience being in their body in a calm way and realize that they can interact with the world in this way that they had never perceived, and then realize all that they had missed because they were engaging with the world in this haphazard, overexcited way. There's more grief when they're older. And so that component of therapy after starting medication is pretty important. But it's absolutely that, right? Like, in the diagnostic process, it's important to tease out dementia, to tease out menopause, to tease out retirement and loneliness, right? Like you have to, because those things too, right, or sleep problems. You still have to get at sort of the lifelong experience, or is it something that just happened because of a change in their phase of life? But if it's someone who's been struggling with it their whole life, it doesn't matter how old they are. The treatment still works, and it works incredibly well. Yeah. Yeah. Please. And I can, if you want to speak in another language, I can.
No, that's okay.
Okay.
Thank you. That was really a great talk. I would have 10,000 questions, but I'm going to just focus on one. You have today much more kids who are diagnosed with ADHD, and for some of them, they're pretty well followed by neuropsychologists. They have a whole treatment. Do you think that when the ADHD is diagnosed early and taken care of very early, there is a way to develop coping mechanisms that actually prevent all that you were talking about in adult ADHD? And if it is the case, would it be possible to do without medicines, or would you recommend in any case to continue with the medicines because it's much better for the person?
So I've seen a few patients who, with very intensive therapy and changes in how they live their life, changes in how they feed themselves, how they sleep, how they find community, can actually, they'll be on the medicine at first to sort of soothe things and make change possible, but then they can actually come off the medicine and they don't need it as much because how they live their life is very changed. That would be hard for a child unless there is significant change in the family system, because there will be stuff in the family system that makes it like the parents would have to change all kinds of stuff too, right? I think the most important part of treatment in a kid is awareness of what we're really doing. Still very much in children, the approach is one of, I feel bad putting you on this medicine. I'm going to kind of take away your personality a little bit. I'm going to make you emotionally numb. You might be going to be a little bit of a robot. Really what I'm doing is making it better for the other students in the class and for the teacher because you're just a problem in the class, right? And it's less about understanding what, we feel bad doing it. But if you approach it instead, when I was in fellowship, this was kind of one of the things that pushed Stanford to, I was working with a child doc who was 25 years my senior, and he had this patient. He was one of the few very lovely attendings who actually wants his trainees to speak their minds, right? And there was a kid who had been on meds for 4 years, and where they were at was the liquid form that they were using didn't taste good. Well, this was 8 steps down the line. What was going on was this child didn't want to be on the medicine and had figured out that he could do it for 2 weeks or 3 weeks after each appointment and then figure some justification for I'm not going to take it. And then that would give him 2 months or 3 months till the next one when they would figure out that problem. And I just asked if I could talk to the child, did he want me to, and he did want me to do it. So I said, hey man, was like a 12-year-old boy, and he liked baseball. And I said, how's baseball? Great, okay. How often are you in the dugout and the other boys make a joke and you don't know what the joke's about? How often do you run out to left field instead of right field, or run out and realize you forgot your glove, right? All of these things. And his response was, that's ADHD? Right? He had no idea. He thought it was sitting still in class and doing his homework, right? No idea that it was about missing the jokes the other boys are saying because he's floated away. And at the end of that appointment, it was he asked his mother if he could have medicine. Once we realize that that's what we're doing, that we're helping someone be more in touch with their own body, right? You'll have a child. This is like you'll have a child 3 days in, come in, they're so excited. Like, I had to pee and I just went. And it's mind-blowing for them, right? And so that, I think, I'm not sure if they can come off the medicine ever, maybe, but certainly during their formative years, their social experience will be different. They won't feel as bad about themselves. Their experience in school will be different. They will be able to learn. They will be able to perceive social dynamics, like all these things. They will learn how to feel their body, right? Like, I have plenty of patients on stimulants who lose weight, but I have plenty of patients on stimulants who gain weight because they're more aware of their body, right? You just take it in a consistent way. Once we know what we're doing, it changes things a lot. I don't know if they'll be able to come off the medicine, but it can be pretty profound. Yeah. Please.
Hi, Dr. Winkler. Thank you for your presentation. So we were talking here, and we were curious about, could you elaborate a little bit more about trauma and ADHD? Because you mentioned that normally at 4 years old, normally the patients go through a situation where it can be traumatic and they disconnect from themselves. So do you believe that all ADHD is associated to trauma? And if not, like, what is the difference between ADHD and ADHD associated to trauma?
So, yeah, it's a great question. Thank you. Also, Dr. Arguello is the one who translated the symptom tracking into Spanish. It's a very good question. It's hard to be precise. I think there's all kinds of trauma that happens to children, and there are plenty of children who have traumatic experiences in childhood and they develop some adaptation that ends up working for them socially. So it's not a diagnosis. It's just you're, a very good musician, or you're something, right? And if it works for you socially, then it's not a problem. And there are plenty of children who experience incredibly traumatic environments and somehow come out just fine. So it's hard to say, like, what the actual thing is. What I can say for certain is the anosognosia, the lack of awareness of the symptoms, fits very well for this develops sometime before 5.5, when real or not real happens. Parents in the room will know what I'm talking about. When your child is like, is this really real? For like 3 or 4 months, as their brain has just discovered the capacity to discern. And it's sort of everything, and then right after that, sort of everything under that gets subsumed, and that is now all unconscious, right? But you can access it so easily, which is why I say 4 instead of like 1 or 2. And they're also not as damaged as people who have like reactive attachment disorder or real struggle when they're like 6 months old, right? Maybe that goes more to like a schizophrenia or something like that, right? Yeah, the word trauma, and like, what does that even mean, right? Like, is that an alcoholic parent? Or is that a parent who was working 2 jobs? Or is that just a parent who, like, a younger sibling was born? And so they were like, you had to yell at the 3-year-old because you just got the baby down for a nap, right? That's the kind of thing that over time, right? I also say there has to be a component of trauma because the fundamental experience is one of disconnection from self and disconnection from others, which wouldn't develop by choice, right? I don't think there's any natural biological developmental pathway that is go into imagination to avoid looking at what's right in front of you, right? That seems unlikely. We are made to like look at what's right in front of us, and it's only if what's right in front of us is a primary attachment figure who isn't seeing us or is scaring us, and that's dangerous, and we can't allow that because the primary attachment figure has to be ideal or we shatter. So we just don't look at it. We learn how to not look at it. Focus on the periphery, right? Look away, blame myself, get into my imagination, like anything to avoid breaking the primary attachment idealization. And that's why I say trauma, because there's something in the inability to, there's something in the default mode network just punching through and going into daydream that blocks awareness of basic physical cues and blocks awareness of what's happening outside of you, that it just seems like it's an adaptation. But we would have to talk for days about that. Am I?
Merci. Alors, juste une question sur ta pratique à toi. Dans ta file active des patients que tu suis, tu as fait référence à la comorbidité, j'imagine psychiatrique. Quels sont les tableaux que tu as le plus à traiter? Quelle comorbidité psychiatrique tu vois le plus? Et comment tu traites la comorbidité lorsque tu as des TDAH associés à une autre pathologie psy?
So it's everything. I have patients with schizophrenia, I have patients with bipolar disorder, I have patients with PTSD, patients with anxiety, depression. Usually depression evaporates with ADHD treatment. And it's interesting because it happens about on a timeline of SSRIs. So there's the initial benefit to focus, right, in the first couple of days. But when patients are on a stimulant every day, just every day, and you have to do a titration up once or twice because they'll get tolerant to it. You don't go up forever because you're not going for energy. You're just sticking with calm, right? After about 6 weeks, 4 to 6 weeks, there's a significant mood benefit. It looks very much like SSRIs, and depression just kind of melts away. With bipolar disorder, if it's bad enough, it's pretty hard to have somebody on a stimulant. But if somebody's stable on like a Latuda, I've had patients do very, very well. Then it's much more about the stability of the patient and their insight and their ability to be able to trust them to like really take their medicine every day. And if they start to feel manic, they're going to stop taking the stimulant and they're going to double up on their Latuda today. Patients like that can do very, very well on a stimulant. Schizophrenia is almost impossible because the dopamine interaction is tough. When it comes to substance use, you can kind of tell actually if someone is drinking 5 beers a day but is doing it to self-medicate, and you'll give them the stimulant and alcohol use drops almost immediately. But there's other patients who are drinking regularly and they're still sort of in a mode of trying to escape. If it's THC, if it's marijuana, if they smoke more than once a week, they kind of have to stop because that chemical builds up in your system and it works contradictory to it's a dissociative, and the ADHD medication is an associative, I suppose, right? And so you'll have to go higher on the stimulant to maintain efficacy, and you end up pushing into a side effect range, but it's because you're having to overcome the action of the THC. So THC, I usually have people stop. Yeah, but a lot of substance use goes away because so much of it is self-medication. Yeah, I find that when it comes to what you're really looking for is somebody who's stability seeking, somebody who, they're struggling but they want things to get better, versus somebody who is just trying to get help, and that's a lot of the dynamics are in there too, versus somebody who just wants to. They've started to have struggles in their life because of how they're living their life, but they don't actually want to deal with that. They just want to get some more energy to be able to keep the train going longer. Yeah, but that all comes out, and it comes out in the symptom tracking too. You'll get plenty of comorbidities in the symptom tracking. People will write in their symptom tracking stuff that is clearly trauma or clearly anxiety or clearly depression. It's incredibly helpful. I've had patients write floated away for 6, like no memory of the day. I had a patient write 7 days, and 4 of the days it said no memory of the day. And he was entirely intact in clinic. And he'd been with his mother, and he was in his 50s, as a patient in his 50s, and his mother had serious borderline personality disorder. And that was just trauma. And I told him 2 months of trauma therapy and then come back and we can talk about it. And he went off and got his trauma therapy and called me back 2 months later and said, I don't need it, thanks very much. The trauma therapy is what I needed. Right? Yeah, it's it's ADHD, right? All the comorbidities, but there's ways to deal with all of it. Yeah, almost all of it. Yeah. We have to stop, right? Are we stopping? Got to stop.
Merci beaucoup.
Yeah, I'm happy, yeah.
On a encore du
Thank
temps? Non, c'est fini? OK. Merci beaucoup. Thank you very much, Aaron.
Yeah, that was lovely. Yeah.
Fantastic.
Mm.